Tonight is our fifth in our speaker series, and I am just delighted that we are able to bring you one of our own, Dr. Ellen Geminiani, who's a member of the class of 1979 here at Ursuline and is a sports medicine physician here in Boston at Children's Hospital. A few odds and ends of housekeeping messages before we get started. Dr. Geminiani will be speaking for about 25 minutes, and then we'll be taking your questions. If you would, please direct the chat questions to Ursuline Academy, the host, and we will send them along to Dr. Geminiani. Thank you all also for carving out the time to be with us tonight. I know that Red Sox game is tempting. We've been watching the score very carefully over the last 15 or 20 minutes, and let's hope they have one of those rallies perhaps in the 9th inning. But for now, we're delighted to be together for our program this evening. Our 75th anniversary speaker series has fallen right in line with the objectives of our 75th anniversary. It's been all about building community and having conversations. And that's what we're delighted to have you with us here tonight. We are also delighted to be continuing the celebration of 75 years of educating remarkable young women. This began in our Arlington Street location in Boston and has continued since the late 1950s in Dedham on the campus that most of us know now. And I think that brings us to the end of our housekeeping remarks. So without further ado, and because I'll allow Dr. Geminiani to share her own bio with you, I am pleased to introduce a fellow alum. The focus of tonight's remarks will be preventing injury among our athletes. We know how important physical exercise and activity is, especially for young people. Whether a student is playing on an organized team, running for her own pleasure, or perhaps a dancer or an ice skater, what's most important is that we keep these young folks injury-free whenever possible. So Ellen, as that is your area of expertise, I'm delighted to turn this over to you, and thank you for being with us tonight.
Thank you so much, Kate, and welcome to everybody. Oh, there we go, share, sorry. There. And as Kate said, I'm going to just sort of give you a little bit about how I got where I am and then spend most of the time talking about what I do and how it influences and how we work in injury prevention into our day-to-day jobs as sports physicians. And I appreciate certainly the opportunity to speak to everyone this evening on a very important topic, I think, and something that I don't feel is spoken about enough, and hopefully as time passes we'll gather more information and this will become more of a topic of discussion. So as Kate very kindly said, I'm a graduate in 1979 from Ursuline. During my years at Ursuline, I was a competitive figure skater, so that was a very big part of what I did. And so my focus was on academics there, and then I would run to the rink and skate. But my interest was always to go into medicine. And so I pursued my bachelor's degree from Wheaton College in Norton, then went on to Albany Medical College in Albany, New York, to get my MD degree. And then I chose family medicine for my residency training, which I did in Pennsylvania. And as part of my residency training, I felt that I needed to have more experience to be a good family physician on musculoskeletal medicine in terms of understanding injuries and how to examine joints and just be very competent or feel confident in diagnosing problems. So I took a month of rotation in sports medicine, because this was a relatively new field way back then, especially for primary care physicians. It was mostly in the departments of orthopedics in surgery. And I kind of figured out at that point that, hey, maybe I can combine this interest in figure skating with my career as a physician, or at least in part. And so I was fortunately able to do that. Okay, hang on. There we go. So when we look at sports medicine, it's really a very multidisciplinary area. It's not just docs and orthopedic surgeons. It encompasses athletic trainers, physical therapists, psychologists, dietitians, sports scientists. And I think that was what in part drew me to this, was because of sort of the comprehensive nature and the very collaborative nature of sports medicine. Working between disciplines in the basic sciences as well as clinical sciences. And essentially, we evaluate injuries, we rehabilitate those injuries, we get people back to sports as quickly, but as safely as possible, is an adage we all have. We want to try to improve performance, of course. A better trained athlete becomes then a better performer in whatever sport. And then, of course, to prevent injury, which we're going to talk about in more detail later. So a sports physician, as I said, we look at musculoskeletal conditions, injuries. My surgical colleagues, orthopedic surgeons, deal with the operative aspects of that, whereas myself and my primary care colleagues deal with what we call the non-operative evaluation and treatment. And there's actually quite a bit that we can do short of surgery. Musculoskeletal injury does not automatically mean one needs a surgical procedure. We also work with athlete illnesses. We help athletes that have chronic conditions such as asthma or diabetes, or if you're a team physician, you'll often deal with the bugs that go through the team, especially traveling. Injury prevention, as I said, exercise prescription, and again, as a family doc, helping people know what to do for exercise. How much do I exercise? What's safe for me? What do I have to do to be productive and either lose weight or get my heart in shape? We determine the ability and the safety of play, either as you're entering into a sport or an exercise program, or after recovering from an injury. And because of the number of different disciplines that are involved, we help coordinate the care for the athletes within those disciplines, sort of the captain of the ship type of thing. So as a sports physician, you can be a team physician, which involves being part of the medical team for scholastic athletes in high school, college, sometimes with local clubs, rowing clubs, the Skating Club of Boston, for example, where I'm the team physician. You can work with the national governing bodies of different sports. Like for me, it's figure skating, but USA Swimming, USA Hockey all have medical advisory boards that you can participate in and be involved in decisions and planning, and hopefully being able to prevent injuries and keep the athletes safe. You can go on also to work with the USOPC, the Olympic Training Centers, support the athletes at Olympic Games or at their training centers. They hire staff to work there. So there's a wide variety of opportunities to participate in whatever it is you find most gratifying or interesting about sports and sports medicine. So we all are well aware of the benefits of sports and physical activity. This is well established in literature, and it's good for us to exercise. Playing sports, though, does involve a risk of injury. We all kind of know that, but most people sort of dismiss that and they just want to sign up, right? Because it's fun. We know that 40% of the sports health-related benefits from sports get lost due to the negative effects of injuries. So that can be a big damper on the benefits, take away from what you were hoping to achieve, either in terms of accomplishment or just fitness. Injury surveillance tools can be helpful to evaluate the injury patterns. I'm going to talk briefly about that. Sports medicine physicians do evaluations, and that basically involves, like any other visit you probably had to the physician. We talk about the history, but our focus in sports medicine is about the mechanism of injury. So basically, how did it happen? And, I'm always asking about, okay, how did the ankle twist, or which way did the knee go? And, the kids are sometimes like, I have no idea. But it's helpful to know which direction the tissue was stressed to have an idea of what structures may have been vulnerable. And we also want to know about the symptoms present. Was it a quick thing that went away, or has it been building and getting worse? Our examination gives us clinical data for making a diagnosis, and we often support that with diagnostic studies such as X-ray or MRI. Once we identify a diagnosis, or what we call a working diagnosis, we start a treatment plan, includes physical therapy, rest, possibly surgery, depending on what's going on. And then for me, the important part is injury prevention. So if I have an athlete that comes in with an injury, it's great. I can tell them what to do to make the injury better. But if there's a particular aspect of their training or their anatomy or something about how they're doing things that is going to put them at greater risk, I want to make sure I address that, because if I don't, I didn't do my job. So as you can imagine, injury prevention is, of course, an important part of sports medicine. Each sport kind of has its own unique type or pattern of injuries that develop, and that pretty much informs how we can focus on recovery as well as return to sport, and then injury prevention. So we identify the patterns of injury through injury reporting or surveillance systems, and that can be helpful data to know about where the injury occurred. Was it the knee, the ankle, a concussion? What was the mechanism? Many of these surveys will be helpful with, and also the time lost. But on the clinical side, research into data of like visits to like the emergency department or to sports medicine facilities can be helpful in identifying patterns of injury as well. And I think in many cases, from my perspective as a clinician, gives a little bit more information to understand what we might be able to do to change things. So one of these injury surveillance systems is called School RIO, reporting information online, pretty basic, but this is a system where high school athletic programs or departments will report their injury rates based on the situation that's occurring in each given sport. So it can be quite variable. They have to do the reporting, so it's a little bit sometimes unreliable that you may not have all the data. But it can be helpful to see, is there a trend? What's, again, the pattern? What's more common? And if you look at pulling out just some girls' sports that are covered in the School RIO program, these are the only 4 that they cover. So right there, we have a little bit of a limitation because we don't know if it's girls hockey in there or field hockey or what else is missing, cross country, track. But this at least gives you a flavor that, okay, in girls soccer, concussions, ankles, and knee injuries. And in volleyball, it's ankles, concussions, and knees. So there's a trend there. So this gives us information to say, hey, we need to really pay attention to probably ankles, heads, and knees for a lot of these sports. So when you look at, injury fits into the center, but there's the RIO, there's the National Athletic Training Association, there's the CDC, which also collects data and tracking injuries. So there's a lot of different resources, and I think you have to kind of look at all of those critically to see what information it might give you that would be helpful in your particular question or problem that you have. In clinical research, many facilities, ours included at Children's, we review the data from sports visits to see, okay, how many, one of my fellows a couple of years ago we looked at all figure skating injuries over the last 15 years. And okay, what was the pattern? What did we see? There are organizations that will follow emergency department diagnoses to see how the visits are trending. And each national governing body or each professional sports organization may track their own injury data as well. It's not a particularly globally organized system. It's kind of individual to a particular program or organization, which I think makes it a little bit more confusing. So you have to kind of weed through and find, again, what you need. In 2015, the American Medical Society for Sports Medicine put out a consensus statement on injury prevention and the team physician. And as the team physician, you have a very central role in everything that happens with the team in terms of training, as well as taking care of injuries and getting them back on the field. So these were some of the recommendations for having the team physician be responsible for understanding the pathophysiology, meaning how did the injury occur? And like I said before, I can take care of your injury, but if I don't fix why or it came about, if that's possible, if there is a causative factor, then we've not really done our job. Identifying risk factors is an important element as well, and then strategies to modify those risk factors. And we'll talk in a minute about what are the risk factors. And, some are modifiable and others are not. Your anatomic alignment, we can't change. That's just you. That's how you came. But if you have tightness in one muscle group or imbalance of strength from one side to the other, those are fixable things with rehabilitation. Also advising on selection of equipment, some modifications that have been recommended over the years, mouth guards to help with dental injuries, face shields to prevent eye injuries, breakaway bases in baseball, since we're have the Red Sox there, especially in Little League, so that minimizes knee injuries. And then, of course, modification of rules and fair play to try to keep it as safe as possible. So when we look at risk factors, I kind of think of it as intrinsic and extrinsic. So intrinsic is within the athlete themselves. So anatomic alignment, we can't really change. But as I said, muscle balance, fitness level, we can afford improvements on that with a proper training program. We can modify their nutrition. We can't change growth and development. I'll talk about that in a second as well. That's just kind of physiology, genetically programmed, and you're going to grow when and how you're going to grow, no matter what sport you're doing at the time. Gender, of course, is unchangeable. Extrinsic factors such as training, conditioning, surface, footwear, equipment, coaching strategies, all of these can be modified. But we want to make sure if we're going to modify these things that we're doing it with good information and for good reason and focus on the safety of the athlete. So these are kind of the factors that we consider as we're looking at how to improve and prevent injuries. So as I said, bones grow at whatever pace they're going to grow, and that's a genetic predisposition for each individual. The bones grow first, everything else has to catch up. And when bones grow first, you lose flexibility in the muscles because tendons connect the bones across joints. And so when the bones grow more quickly, the muscles are under more tension, and that can create a skeletal vulnerability at those attachment points on the bony structures. And that's, of course, a risk for overuse injury. Growing pains is what we talk about when we're talking about these growth and development problems. And I think a lot of parents are surprised when I tell them that, it can take 24 to 36 months for them to navigate through all of that growth spurt. And the example I use is, if an athlete grows 3 inches in a year, their bones grew 3 inches, but the muscles and tendons only grew 1 inch. So right there, just even if everything else is equal, we're at a disadvantage in terms of tightness. So that's a risk factor for injury. We know that girls start on average the growth spurt around 9 and boys around 11. But again, there's a wide range of that within individuals. And we also have to remember that those tendon attachments on bones have growth plates. Just like the ends of bones have growth plates, tendons have a type of growth plate called an apophysis, and that's a vulnerable skeletal tissue. And when the body changes that quickly, you're going to lose flexibility, you might lose muscle strength probably, and then things can get out of balance very easily, and then the body starts to compensate because it can. and it will if it has to. And so that's where we have to be very aware of what training is like during that growth spurt. One of the bigger categories of injury that we talk about a lot in sports medicine, and there's vast research on this for the last maybe 40 years, it's an increasingly common injury, and it's a very debilitating injury at the same time. There's substantial acute and chronic morbidity from this, as well as substantial cost. Majority of sports injuries requiring surgery are the knee injuries, and about 50% of the knee injuries are ACL injuries, upwards of now 200,000 cases per year, they estimate, which is not insignificant, especially because this is about a 9 to 12 month recovery for the athlete before they're back to sports with rehabilitation. So this is one we need to pay attention to. The pictures at the top show on the left a normal ACL. You can see the red with the torn ACL and then a reconstructed ACL. In the past, they've tried just sewing them back together, but that didn't work. And so now we reconstruct, replace that ACL with another structure, usually a tendon. And the MRI imaging below shows that nice dark black ACL on the left. And then it's kind of gray, white, kind of fuzzy stuff. That's a torn ACL, and that's not what you want to see on the MRI. So that has to be removed and replaced with a different structure, at least at the standard right now. There is some research into different methods for correcting this, but it's been a long-standing problem. The high-risk sports for ACL injuries are soccer, lacrosse, basketball, and football. And so depending on the types of sports you play, there are some athletes that play soccer in the fall and basketball in the winter and lacrosse in the spring. And so some of my colleagues refer to that as the trifecta of risk for injury of ACL. We know that there's more incidence of these injuries, and in part is because of increased sports participation. So the more participation you do year-round in different sports, that's an increased sports exposure, which then in turn increases your risk. Also, early specialization, and I'm going to talk a little bit more detail about that in a sec, is another risk factor. We also know that there's varied development and growth. Right? There's averages on when adolescents grow, and how that affects the stability of the ACL can be quite variable. Not to mention, you could take a line of 12-year-olds and there would be a vast difference in height, in weight, size, body habitus. So that is another factor, I think, especially in the adolescent age group. And we do know that these injuries are more common in competition. Women are significantly higher risk than males in the same sport, all things that similar. Girls tear their ACL way more easily than boys. We're not sure exactly why that is. We think it may be the width of that notch. You see where the ACL falls there. If that's more narrow, the ACL is crowded. They think that is a risk factor. It's been pretty well proven that what we call the genu valgum, or that knee pushing in, you can see the young lady on the left has a nice straight line, even with her pelvis on the alignment of the knee below. But the girl on the right has a tilt and a dip into the knee, and that puts the ACL in a very vulnerable position. We also know that weakness of the hamstring, especially relative to the quad, is a big risk factor. And then weakness at the hip, because if you can dip your hip, your knee's going to valgus in. And so then that places that ACL again under greater stress. So some of these, we can't change the width of the notch in your knee, but we can affect improvement in how you land with mechanics and such. Girls soccer and gymnastics are among the highest risk in terms of ACL tears for sports. And girls have a 9 times greater chance of tearing an ACL in a game compared to boys in the same sport. So the young ladies are at a great risk for this. So we're always kind of worried about that. As I said, lower extremity core exercises, plyometric exercises, which are very powerful jumping, quick change in position. And you can train the leg on the landing to be stable and have that core assist to keep everything nicely lined up so that ACL and that knee doesn't take all of the force of those movements. It takes a while for the athlete to learn this neuromuscular feedback. And so that's why doing these rehab programs is very helpful. In 2020, there was a study that showed that these rehab programs can reduce ACL injury by about 50%, which was quite remarkable. And the prevention programs, even though young women have the highest risk of injury, they show the greatest benefit from these prevention programs. So it's a good thing to incorporate into training. Concussions are another very common situation, as we all know. The highest risk is in collision sports. It's estimated about 1 to 1.8 million sports-related concussions per year in the 0 to 18-year age group. And recovery, as many may have experienced, unfortunately, creates a significant burden on academics as well as on their sports participation. There was a recent study that showed that age 5 to 18 with a previous concussion had a 4 times greater risk of another injury, even if they fully recover. So, this is not insignificant, especially in these young athletes. And women, again, are at a higher risk of concussion, sustaining a concussion, as well as having a higher symptom burden, longer recovery. It's felt this may be related to hormonal influences because there's some evidence recently that there may be a similar mechanism as with migraine headaches, which we know are influenced by hormonal changes. And then neck muscle strengthening and biomechanics are important. So to prevent concussion, we change rules. Things like in hockey, they don't do checking until I think it's 14 or 15 now, depending on the league, modifying tackling in practice. And even the NFL is not tackling as much in practices anymore. Mouth guards, helmets, headgear, all of those things have been touted to be beneficial, and there is some evidence that it could possibly help, but it's not clear cut. And one thing we worry about when people think, oh, well, I'll just get the better helmet, then I won't get a concussion and I can do what I want. And so similar with the headgear in soccer, I think it helps the athletes to feel a little bit too empowered and not, I don't want to say cautious, but they have to be aware of how they're moving. But cervical strengthening is definitely an important factor and has been shown to be helpful. So I wouldn't run out and buy everybody a helmet or headgear for their sports. Although helmets will prevent terrible skull fractures and will save lives. So I'm not saying don't wear a helmet. I'm just saying don't expect it to prevent your concussion. Ankle injuries are also very common, as we saw. Inversion, or the rolling in, is the most common. You have to think of fractures, tendon injuries as well. These have a high rate of recurrence, and that's usually because you've injured it before and never fully rehabilitated it. You can end up with some laxity of the ligaments, but usually they'll tighten up with time. And we know that by doing muscle strengthening and work on motor control and balance, that helps prevent these injuries from recurring. Bracing has been shown to be beneficial in ankle injuries, but not really any other joint bracing. So sports specialization is an area that's gained some additional interest and attention in the last, maybe 10, 15 years. Sports specialization refers to year-round intensive training in a single sport, to the exclusion of all other sports. And what that creates is an intense, high-volume training situation that has a very high risk of overuse injuries and burnout. And then you add to that factors in young ages, both the growth spurts, overscheduling and fatigue in young women, especially in the aesthetic sports of gymnastics, skating, dance, amenorrhea, which is a risk for their bone health long-term, and then of course the high training volume. Overuse injuries were found in pediatrics to show about a 2-time higher risk in these early specialized sports programs. And many folks feel that they want to get involved in this sports specialization very early because of a desire to pursue either college or professional goals. Or in sports like skating and dance, it's almost impossible to get into those without starting very early. So to prevent issues with these sports, I think it's workable and doable, but you have to monitor that training workload. More isn't necessarily better. You need to limit volume to the number of hours per week in training should not be greater than their age. And we know gymnasts, 10-year-old gymnasts train 20 hours a week. It's too much. Very often people are in, soccer, they're in school soccer, then they're in club soccer, then they're in, another spring soccer league, and then summer soccer, and it's just a constant thing. Same with basketball. And it just can lead to a lot of difficulty and burnout. Kids are still need to be kids. I think education of coaches and parents of these concerns is important. And so I appreciate you guys taking the time today to hear about it. And really, the early specialization is not a guarantee of sports success. So I don't think we all have to be in such a hurry. I think we need to take our time. I think you can certainly start developing skills athletically as a young athlete. But that doesn't mean that you're super specialized into just one thing at that early stage. So injury prevention overall pretty much is assessing the injury patterns that we talked about. We can do a screening assessment, as I mentioned, in the office, and sometimes we can set up a specific sport-specific injury assessment, looking at issues with flexibility, with strength, identifying those modifiable versus non-modifiable risk factors, and then evaluate each athlete for their own unique risk factors with basic clinical and sports science tools, and then develop the training program to be corrective for those, and then prepare the athlete for their sport. I always say, you can't become a well-trained athlete just by playing a sport. You have to do stuff outside of it. And that's only going to prepare you better and make you a better performer in your sport, but also then keep you safer. So again, those risk factors, just as a review. And so the complete picture of injury prevention is, as I said, that individual athlete assessment, the fitness needs, the strength and flexibility, core stability. You want to vary the emphasis through the year. There's no issue with practicing or doing activities year round, but you want to plan it out a little bit, and it can't be 150 miles an hour all the time. It has to have some recovery periods, because tissue needs that to recover. Otherwise, you end up with overuse injuries. And then be cognizant of their stage of development in puberty and adolescence, and training the right systems. Questions? I think there were questions. Are you going to read those, Kate, or do you want me to go through these that were sent in early?
Ellen, I'm happy to read them off for you.
Okay,
Thank
but
you. Yep.
Okay, I didn't want to mess up the
No.
protocol.
You won't mess up anything. And thank you. That was really interesting. We have a wide group of people with us tonight. We have Ursuline parents, some past parents. We have some of our coaching staff on, as well as some friends from outside of Ursuline who have joined us. So
Fantastic.
I encourage all of you to put questions into the chat feature, and we'll get them to Ellen as quickly as we can. So starting off with some of the questions that people were kind enough to submit before this evening. First question is, would you discuss how to manage overuse injuries, specifically shin splints?
Yeah, that's a great question, and it's a very common problem, especially now in cross-country season. I'm seeing quite a lot of that. I think one of the biggest risk factors for shin splints is over the summer, the athlete may train a little bit, but probably not enough to meet the demand of what the coach often wants to do at the very beginning. So we say you should start at about maybe 25% of where you want to be ultimately, and then increase 10% per week. So I have many athletes come in and say, oh, I didn't run at all. And then I showed up the first day of practice and we ran 3 miles. And that's not going to go well, right? And maybe the first day you get away with it, but after a while it can catch up with you much more easily. I think the other thing that's important is stretching, especially the Achilles, the back, the calf, because when that's tight, it tends to make the body pronate or roll in on that ankle, especially with running, and that can put tension on those lower leg muscles. Making sure your shoes fit properly, that you have good arch support. We all have different shapes to our feet. Some of us roll in more than others. Some of us have flatter feet. But even a high arch needs to be supported. Otherwise, you're going to put more tension on that lower leg. So it's important, if you have kind of a different alignment to your body, that you pay close attention to how your shoes fit and have someone who's knowledgeable, a coach who's knowledgeable. Your athletic trainer is very knowledgeable and can be very helpful with this. That you've got the right shoes, or maybe we need an insert. Also, I can't tell you how many runners don't know how many miles should be on a pair of shoes. About 400. Okay. So if you're running on dead shoes, you're going to get shin splints. That's just a fact. So I think if you're struggling with the shin splints, get somebody to help you out, either physical therapy or your athletic trainer. I think we need to look at your feet. We need to look at the support you're getting in shoes. There is a possibility to do a gait analysis that can be extremely helpful. We know that the length of the stride and how you strike on the heel and all of those things play a role in developing shin splints and stress fractures, for that matter, in the lower extremity.
Okay, thank you. That was great. We're going to switch from running over to volleyball now with our next question.
Okay.
Besides knee pads, does any other padding exist for volleyball players who need to dive for the ball, like hip or elbow padding?
That's a great question. Again, maybe your athletic trainer is going to be more knowledgeable about that. There are elbow pads, because I know wrestlers wear them. Some basketball players wear them, so they're not whacking their elbows and getting bursitis there. I don't know how helpful those are, or for volleyball, or how easy they are to keep on. There's not a specific hip pad. But I will tell you, in skating, we have now like these, they're almost like puffy pants, and they're all padded with foam, and the kids wear them. And, I wish they had that when I was falling on the ice, but, so you could think about something like that. I think they tend to be more for the buttocks, the gluteus, but you could probably turn them around and use them for the hips.
Okay, good. Thank you.
That's a MacGyver thing, isn't it?
It is. It is. Next question. What is good preventive care for knee, hip, and ankle injuries and soreness for runners and lacrosse players?
Okay, this is a great question and covers so many important areas. The body needs to be flexible and strong in order to perform at its best. So, you can go to physical therapy, and I have athletes do this all the time. They go and they work on it for a couple months, they feel better, and then they stop doing the exercises. Okay. Unfortunately, you will not be gifted with strength and flexibility just by doing it for 8 weeks. You have to keep it up to maintain it. It's like practicing. If you don't practice flexibility or practice getting stronger, you're not going to get flexible and strong. Just like you're not going to get better at baseball or softball or whatever it is you're playing. So you need to do that on a consistent basis. I think one of the areas we see most is that the hamstrings stay so very tight, especially in runners. So you've got to stretch them all the time. You know, sometimes rolling beforehand is great. It can soften up the muscle, but it will not make you flexible, but it can help make that tissue more pliable. And then if you can get good instruction on how to do static stretching on your hamstring, on your hip flexors, on your Achilles, at the end, after running, muscles are nice and warm, they're kind of sore. Actually, stretching can help mitigate that a little bit. So stretch, stretch, stretch every day, every time you run, and then work on strengthening. You know, a lot of runners think they don't need core strength. They absolutely do, because that makes you stable, and then your legs aren't doing all the work. Your hips and lower abdominal muscles are contributing their share.
Good. All right. Is there an age, in your opinion, that is too young for a child to participate in physical contact sports?
Yeah, that's a great question. And we don't really have a good concrete answer. There's still a lot of research going on. I think hockey, has it right that you don't want to be deliberately going after checking and hitting and that kind of stuff before about age 15 or so. Now, that doesn't mean that you're not going to get some head contact and that in sports otherwise, but I think deliberately go after it, you know, or allow it earlier than that is probably asking for way more trouble. We all know, even though there's no checking in the younger leagues, it still happens. So if we can keep that to a minimum. So I would say, you know, we usually, 13, 14 is about the oldest, I would say, to get into real high impact collision kind of stuff.
Okay. Moving back to volleyball for a minute. This is from a parent who says, when my daughter plays volleyball, she complains of numbness in her feet and pain.
Mm-hmm.
She says that she can't feel her feet, even though she's wearing her most comfortable volleyball shoes.
Okay.
What's the cause and treatment for that? Is there a preventive measure to take before the game?
Mm-hmm. That's a great question. And that's something that we would need to figure out, why she's having that numbness. Is it because, you know, she's in her comfy shoes, but are they not providing enough support for her? And is that tugging on one of the nerves? Usually tingling and falling asleep numbness comes from a nerve getting irritated. That can be from pressure or compression, from a muscle, from equipment, and what commonly, like we have it, people are familiar with carpal tunnel. You can get what we call tarsal tunnel on the inside part of the ankle. And if that structure is either under a lot of tension from foot rolling in or compression from equipment, skaters get that sometimes, skiers, because of the pressure from the boots. That can be a factor. I think to get a definitive diagnosis for that would be important for that family. And, you know, I would have somebody take a look at it, maybe physical therapy, maybe looking at the footwear. Those would be a few things that I would recommend, because that, even if it is that tarsal tunnel, it's very amenable to physical therapy treatment.
Good. Okay. This will give you a chance to maybe emphasize the point you made a few minutes ago. Is there any one most helpful thing that a student athlete can do to reduce the risk of injury? Is the pre-work stretching all that it's cracked up to be? Or pre-workout stretching,
Pre-workout stretching, yeah. You know, that's been a 1 year it's this, the next year it's that, back and forth, back and forth. I think we've more recently kind of settled into dynamic stretching, and not even really stretching, dynamic warm-up almost, you know, high knees, walking, you know, hip rotation, what they call gaits, where you bring your leg up and rotate it out and come down, almost to warm up that joint before you participate. And then the stretching piece comes afterwards, okay, in terms of dynamic stretching. You should not stretch dynamically, like, you know, lay on the floor and grab a strap and start hauling your leg somewhere. That should happen in a nice warm muscle. So that's why I usually tell people do it afterwards, because it is more effective. You're going to get better results that way. And then you're also not going to risk as much injury. And it might actually help, break up some of that lactic acid that's built up and improve the blood flow there.
Good.
I don't know if that answers the question or not, but
No, I think it does.
it's been a big debate, but I think we're settled on dynamic warm up, participation, and then static stretching.
Good. Okay. Would you have any diet recommendations for training purposes?
Oh, you got to make sure you're fueling the car. If you don't have enough calories to go in, it's going to come from your muscles. That's what your body's going to do, because your body's going to find the energy source. You want to make sure it's a good balanced diet, and there are dozens and more than dozens, many resources out there. A dietitian that you sit down with and works with you based on your food preferences, any intolerances, etc., is always helpful. But just to get information from the American Dietetic Association, there are sports recommendations that they have that can be helpful. But you basically want to have sort of that food pyramid, and the base of the pyramid is good healthy carbohydrates, whole grains, fruits, vegetables in many cases. Then you want your proteins, you want lean protein that's going to fuel your muscles and allow your muscles to grow and develop strength. And then you keep the high refined things, it's the small part of the pyramid at the top. Our dietitians say, there's not anything you can't eat, just make sure it's proportioned correctly. I think we get into what can I eat, what shouldn't I eat, and this just triggers eating disorders. I think, it's about balance, and it's about making sure your body is fueled to do what you want to do. And if you feel like you're struggling with that, or you're not sure how to make that happen, then I would sit down. Even 1 or 2 sessions with a sports dietitian can really clarify things for you. Hydration too is another key element of the diet.
Good. Okay. And I do appreciate a pyramid that allows dark chocolate in it, but that's
absolutely
another story.
There are no bad foods, right?
Yeah.
And this is what our dietitians say all the time. There are no bad foods, but that's chocolate is great, but you can't have chocolate for every meal, right? None of us would make it.
Okay. So we have a question from a parent of lacrosse players, and she comments that girls lacrosse players wear significantly less protective gear than the boys do. Do you see an effort among medical professionals to encourage universal change to prevent further injuries?
I can't say that I have seen that, but I could certainly have one of my colleagues works with USA Lacrosse. I would be interested to know what he thinks about that. But yeah, I think it needs to be equal, right? I mean, you've just got to have more equipment. I don't know that the bigger helmet or the fancier helmet, like I said, is helpful for that skull fracture, but it's not going to prevent that concussive injury, because we know the concussion comes from the brain moving inside the skull. And so you can have the fanciest helmet, unless it tethers your head to your shoulders, it's probably not going to do much in terms of preventing the concussion. But if you hit your head on a hard surface or a metal post, it for sure is going to keep you out of the operating room for a depressed skull fracture. So that's a very helpful piece of it. But I do think it should be more equitable in terms of the protective equipment, because categorize sports. There's I think but basketball was considered a minimal contact sport. I beg to differ. I think that all of those need to be updated, honestly.
Okay. That brings us to the end of the questions that have been submitted through the chat feature. At this point, I would encourage any of our participants who would like to unmute. If you'd like to ask a question directly of Dr. Geminiani, please do so. We've got a couple more minutes left in our program here. So don't hesitate to come off mute and just speak up if you'd like to. I will give a quick update. I believe the score of the Red Sox game is 7-1.
Oops.
Oops. Yeah. And we're at the top of the 8th inning. So.
Sorry.
I think that might bring us to the end of our program this evening. I'd like to offer my thanks to Dr. Geminiani for her time this evening, and it's been informative and interesting and wonderful reminders for us all, even if some of the things we've known, but maybe some of those good habits have gone by the wayside. A special thanks to my colleagues, Susan Hare and Joe Ziska behind the scenes here at Ursuline, who are so integral to making these programs happen. Our next event in our speaker series will take place on December 2nd, and it will be with climate activist and cartographer Molly Burhams, who has done a remarkable job urging the Catholic Church to use its land for environmental and social justice purposes. So that, again, that is on Thursday, December 2nd. Also coming up on Ursuline's calendar, back by popular demand, we will once again be doing our virtual gala, which will be Ursuline's Got Talent. This event was amazingly successful last year, both in terms of those who were watching, for those who participated, and for the school. So I encourage you all to be with us again, if you could be, on Sunday, December 12th as well. There is loads happening as part of our 75th anniversary. And we have been delighted at the opportunity to come together as a community, to forge new bonds and to renew old ties as well. Each one of these events has made our community that much stronger and richer. So my thanks to everyone for participating tonight. Again, our gratitude to Dr. Geminiani for her time. And I wish you all good health, stay strong, and remember to stretch. Thanks everyone for being with us tonight.